It's nice to see everyone again. So I'm going to share a case of hemodialysis access intervention that I did recently. Just a little bit background: 50-year-old gentleman, diabetic hypertension. He's been end-stage renal failure on regular dialysis since 2019. He had a left brachiocephalic fistula for dialysis, which was created in June 2019. And he was referred to me by a nephrologist for a non-functioning fistula in the preceding 1 week. So the nephrologist had already put an internal jugular catheter for dialysis prior to referral to me. He also did a CT venogram, which revealed a thrombosed fistula. Now, I'm not sure how often you guys do a CT scan or ultrasound prior when the fistula is non-functioning. In my experience so far, from all the referrals that I've received for fistula, even for a subclavian vein stenosis, they don't run the proper protocol for venogram, especially the CT scan, and so most of the times when they refer, they say there's a thrombosis or stenosis, and when we go in and do a venogram, sometimes it's actually normal. So for this patient, when I got him, so the plan was to do a fistulogram with view for a catheter-directed thrombolysis. Why CDT for me? Because I've done a number of thrombosed fistula cases and pretty successfully with the CDT. So usually I go in with a plan, and I have a benefit of having an ECOS machine here. And the outcomes are pretty good. So in this patient, he had a good radial pulse. So I actually had a radial access and then took a shot. But unfortunately, I could not see any flow down the venous limb or at the anastomotic site. So I punctured directly into the fistula just above the anastomotic site. And this was a 6 French thermocatheter, but I was careful not to push it all the way in. And when I did a fistulogram, so this was the findings. There was a very tight stenosis at the venous limb and a tight stenosis at the anastomotic, juxta-anastomotic site as well. So at this juncture, of course, I stopped and I was thinking, how do I proceed? Since I have a radial access, should I go from the radial or should I wire directly from the fistula puncture, or should I refer to the surgeons for a redo? But I think I felt that this was salvageable percutaneously, and I didn't think that I wanted to put the patient through surgery. A little bit more, this patient actually has a poor ejection fraction, EF of 25-30%. So sometimes, even though the fistula procedure is under local anesthesia, sometimes the surgeons will grunt and they won't be too happy. So I decided to go directly from the fistula because I felt that I would have a better control of the wire to cross the tight stenosis. Unfortunately, I don't have the images saved when I crossed it. I actually used a 035 Thromo with a MP5 French for support and managed to wire all the way into the IVC. But I took a picture first usually because I realized that a lot of patients who come in with a non-functioning fistula or thrombosed fistula actually have a very tight stenosis, either in the subclavian or at the cephalic vein. And this patient had a tight cephalic vein stenosis. So I went on with I took a 4.0 by 40 mm balloon first because I was concerned that the balloon might not pass the first stenosis, but it went in quite easily. I pre-dilated the cephalic stenosis first, went on to work the whole way and up to at the tightest stenosis, ensured that the balloon opened fully. And this is the results after the 4.0. Now I know I'm quite comfortable to take bigger balloons. So I took a 6 by 80 mm balloon. Did long inflations. Usually I keep it about 2 to 3 minutes, and worked actually the whole length of the fistula. And the stenosis is actually very tight. Usually we know AV fistulas are at least 6 mm, especially at the proximal segment of the venous limb or more sometimes. So the lesion opened very well. Then I took an angiogram. So obviously when you look at this, there's a lot of concern because um, there are a few things that are running through my mind, of course, at this juncture. So I was wondering if I had dissected the vein. I find with vein that you don't dissect it as much with artery. And since there was a concern about thrombus, I thought if I dislodged some thrombus because there was a stenosis all over. And the other thing, I felt that maybe there was some flow attenuation because of the stenosis anastomotic site, but of course I'm shooting directly from the fistula here. So I told myself, it's okay, let's go and fix the anastomotic site first. So what I did was I did a retrograde puncture under fluoro guidance, used 6 French to Terumo, and I managed to pass a 014 command wire. Now, I'm very sure a lot of you were wondering that I had a radial access.
Sorry to interrupt, Dr. Jaya. Only 3 minutes are left for your presentation, please.
Okay, sure.
Thank you.
I managed to pass a 014 command wire. So a lot of you will be wondering, but I had a radial access, why didn't I use it? So what happened was we covered the radial access, and as we were going along with the procedure, we completely slipped our mind that we actually had a radial access. So that's my fault. But anyway, I did a retrograde puncture and it looked like this. So I went on, just used a 3 by 80 mm balloon to open up the juxta anastomotic site, and I managed to achieve a quite good flow, and I was quite happy with this. I didn't want to go any bigger. So back to the venous limb, and it still did good. So I've opened up the juxta anastomotic site. So I thought dissection and clots. So what I usually do is I took a long 50 by 120 mm balloon, did long inflations up to 5 minutes. And because I was going to do a long inflation, I removed the retrograde wire and to help to seal off that puncture, and that was successful. And this was the final results. To be honest, I was quite happy. I knew that there were not dissections. The flow was good in the venous limb and at the juxta anastomotic site. So I dialyzed the patient the very next day. He went through 4 hours of dialysis without any problem. I actually kept him, it was a Thursday when I did it, so I kept him over the weekend. Dialyzed him again on Monday. There was no issue, so I removed the IJC. We just saw him after 3 months. He was dialyzing well without any issues. We did a Doppler, which showed the flow velocity was good, and I didn't have to intervene. With fistula interventions or subclavian vein interventions, what we regularly see is the patient comes back most time within 3 to 6 months, especially with POBA, and they have to do a repeat procedure. So in this case, I think with dialysis access, it's very important to go in early, mainly because if it gets totally occluded by thrombus, and most of the time the venous limb is most of the time aneurysmal, so you get extremely a lot of thrombus, and intervention not only becomes cumbersome, but the cost becomes very high. So I tell my nephrology friends that one clue that we can look out for is when the venous return pressures are very high during regular dialysis. So I think this should warrant early imaging and ultrasound or CT, if you may. So there are some new evidences with the use of DCB in fistulas. A metronic impact balloon just came up, and the patency is prolonged up to 6-9 months, up to a year. So pretty good patency, up to 60 to 70%, if I'm not mistaken. It's off my hand. And also study use of Supera for in implantation at the juxta anastomotic lesion. So these are interesting things. Thank you very much. I'll take some questions.
Thank you, Jaya. That was wonderful. And I have not questions, but my comments. There's no, absolutely your result was perfect. In fact, the veins actually remodel. You don't have to worry about small dissections like you have to worry in arteries. The veins are very forgiving. Sometimes even if you rupture a vein a little bit, it actually helps it to remodel better. And the flow there is quite good. So these veins eventually will increase in size and become quite big and normal. So that was the right way to do it. And Supera, of course, is a very good choice for arteriovenous anastomosis if required. But if you can get without it with a cutting balloon or drug-coated balloon, it's much better. In fact, the first Supera I put on this sort of lesion was in Malaysia when I went for a workshop, and that was many years back. And that was an out of IFU thing. Even now, it's out of IFU, but still, that case actually prompted and a lot of nephrologists and interventional radiologists and vascular surgeons to start using this, and company also to start promoting it as off-label use. But that is a very well done case, and this is how most of the fistulas can be salvaged. And the main objective here is to maintain their patency as long as possible.
Yeah.
To suspect a venous problem, as you said, whenever you have symptoms of venous hypertension or signs of venous hypertension, or you start having reduced flow on dialysis, that is the time to intervene rather than when they come with a thrombosed grafts and thrombosed fistula. So those are quite late. But very well done procedure, and I believe you must have already started a fistula program or interventional nephrology program.
We have just started.
The other day, Saiful was here yesterday, and the other day I talked to him about you, and even yesterday we mentioned about you in the Ironman competition. Okay, so we go to the next case. So it is Dr. Tanya Pereira, who is a senior interventional cardiologist from Sri Lanka, and she's going to be speaking on aortic fenestration in dissection.